So I appreciate the opportunity to talk today. Spend a little bit of time kind of reviewing where we are largely with BRCA1 and BRCA2 related predispositions as a preface, if you will, to some advances that are taking place in this area that we'll discuss a bit more tomorrow. So for a number of years, we've known about familial aggregation as being one of the risk factors for breast cancer. Matter of fact, it dates back really to the time of the Romans when they realized that breast cancer sometimes ran in families. And there were a number of epidemiological studies that were done, largely in Northern European and United States, analyzing the risks that were associated with different configurations of family history. And what was observed was that if you had any close relative, first or second degree relative, affected with breast cancer, your breast cancer risk was roughly twice that of the general population. And if you had relatives that were affected younger or who were closer to you, your risks were slightly higher. And so relative risks with having a mother or a sister involved with breast cancer were somewhere around 2 to 2.3. And if you had multiple family members affected, like both your sister and your mother, your relative risk was up around 3.5. There's a number of possible explanations for that. One possible explanation is that in a big enough family, things can just happen by chance alone. Another possible explanation is that there's shared environmental influences. After all, when you see several cases of lung cancer in a family, you don't think to yourself, gee, there must be a genetic predisposition. You think to yourself, they must all smoke. It's also possible that there are shared genetic influences that are individually relatively weak, but if there are multiple influences all coming together, they can be strong, and that can lead to some evidence of increased risk, so-called polygenic risk. But that doesn't explain families that look like this, where you have multiple generations affected with very early onset disease, often with bilateral disease. Males and females can be transmitting the predisposition equally well, and yet you may not necessarily see it in every generation because of something called incomplete penetrance. And incomplete penetrance means that someone inherits the predisposition but doesn't develop the disease. The other challenge in recognizing these types of predispositions is that if the expression of the disease is gender specific, so for instance breast cancer being more likely to occur in women, ovarian cancer exclusively in women, then if you have a family full of men, you're not likely to see it until it hits the generation of young women. So for a long time there was debate about whether there was or was not any type of predisposition like this in breast cancer, because this is reflective of the inheritance of a single genetic alteration across multiple generations. And really, it was Henry Lynch who first described these families in detail and presented really convincing clinical evidence that there was such a predisposition. And Mary Claire King, who originally did the epidemiological work and then began the biological work to really pin down the genetic sequences themselves. 1994 and 1995, BRCA1 and BRCA2 were cloned out, and all of a sudden now we had a great biological advance, and those of us on the clinical side were sitting there with a bunch of very difficult questions, because the science had sort of gotten ahead of the clinic, and now we had the genes, but we really didn't know who it was that should be tested. We didn't have that good a handle on exactly what the cancer risks were that were linked to the mutations, and we had absolutely no clue of how we should be managing people. And historically, it's interesting that the groups that were originally working with BRCA1 and BRCA2 families were actually psychologists studying the psychological risks of testing. And so when it came to presenting clinical guidelines about the management of these families, it was essentially behavioral scientists who were presenting what they thought were reasonable guidelines, not evidence-based, but hey, this seems like a good thing to do. And those became the baseline for everything that we've done since in terms of managing families like this. So over the years, we've refined our ability to at least think about who to test. There have been a number of empirical models that have been developed to predict the likelihood that one will find a mutation given a particular family history configuration and ethnicity and the like. There have also been a number of groups that have proposed just broad category-based guidelines. Test everybody under age 45, test everybody with triple-negative breast cancer under age 50 or 60. I think one thing to bear in mind is that any threshold that one picks, whether it's a model-based threshold or a category-based threshold, is necessarily going to be somewhat insensitive. The only way to identify every individual with a mutation that's in a population is to test everybody in the population. Are all being driven really by consensus or expert opinion, and often, at least in the United States, by payers, in terms of what they're willing to pay, what their cost per positive test is, not necessarily by any specific medical or biological guideline. So when one hears about 10% thresholds or 5% probability thresholds, these are completely arbitrary. And there's no particular evidence that that is or is not more cost effective or more beneficial for the population at large than a different threshold. And of course, if you're the one family that doesn't fit the category but has the mutation, then that information could still have been very important to you. Now, the question of risks is an important one, and it's becoming more important as we test other genes, because if there's one set of genes that we should understand well, it's BRCA1 and BRCA2. But it's been complicated. The original risks that were predicted out of the Breast Cancer Linkage Consortium, which was the group that identified the genes, were very, very high. And these are the risks that you see on many reports. Breast cancer risks of 85 to 87%, ovarian cancer risks of 30 to 65%, depending on the gene, depending on which study that they use. But these were derived from the studies of families that had multiple cases of early onset breast and ovarian cancer, 4 or more cases of breast cancer with or without ovary, with or without male breast cancer. And there was a very circular process that went into it. You went worldwide, recruited the most impressive families you could possibly find so that you could identify the genes, and then once you'd identified the genes, you went back to those same families to calculate the risks. So there's a tremendous ascertainment bias there, and if one goes and looks at less selected families, the risks are considerably lower. Now, one can argue whether or not these are meaningfully lower from a clinical standpoint, but they are numerically lower. And in a group of families, a group of studies in which families were ascertained without regard for family history, BRCA1 associated breast cancer risk is about 65%, not 85%. BRCA2 risk is closer to 50-50, and the ovarian cancer risks are lower as well. So what are the differences here? Why are we seeing some studies higher, some studies lower? And one hypothesis is that it's just plain old artifact of ascertainment, but another is that there are modifiers either within individuals or within families that are altering the penetrance of these genes in specific individual circumstances. Now, the modifiers that everyone is most interested in are non-genetic modifiers because they are theoretically subject to modulation, so lifestyle types of factors, environmental exposures. And there's some evidence that there could be these types of modifiers, largely that several studies have identified a so-called birth cohort effect. And that means that BRCA1 or BRCA2 mutation carriers who were born in the more distant past appear to have a later expression of the predisposition than women who are born more recently. So the lifetime risks may be higher, maybe the same. But if you're younger, do I get extra minutes for the... So if you're younger, then you're more likely to declare it at a younger age. Nobody understands why this is the case, because all the traditional epidemiological risk factors have been looked at very, very carefully, and there's no really robust evidence that anything, age at first live birth, breastfeeding, oral contraceptives, that any of our traditional risk factors have a reproducible effect on BRCA-associated penetrance. So the explanation for the birth cohort effect remains elusive, and people have really concentrated much more on genetic modifiers of risk. And these pretty clearly do exist. There have been a number of large consortia that have identified common variants which in and of themselves have very modest effects on breast cancer risk in the general population. But these common variants do appear to modulate the risk within BRCA1 and BRCA2 carriers. And these were identified through so-called genome-wide association studies, or GWAS. And while they have not yet entered the clinic, there is a lot of work being done to try to develop more individualized risk prediction models. And this is some work that was done by Antonis Antonou and the group at Cambridge, showing that, in theory, if you have an average breast and ovarian cancer risk, as illustrated by the blue line here, of a group of carriers, if you did genotyping for the common risk variants and then segregated patients depending on whether they had more or fewer high-risk variants, you could split that average into groups of individuals who had higher penetrance and lower penetrance. And that information might be useful in counseling and decision-making. There's a lot of road between here and there, but certainly we're trying to get to the point where we're not just presenting people with the average risks, but instead trying to give them a slightly more refined estimate, and perhaps that might have some influence on what they choose to do. Now, what are the choices for what they choose to do? Again, thinking back to 1994 and 1995, we were stuck with this very stark choice. All we had at the time, remember, was mammography for screening, and so patients had to make this decision. Do I do a prophylactic surgery, or do I do mammographic screening? And interestingly, even back then, the majority of women, at least in the United States, elected to do just regular surveillance and screening and not surgery. Now, we now have pink MRI machines, so it's very helpful. We've got additional information that we can bring to bear, more helpful enhanced surveillance. And we do have increasing confidence in our ability to detect cancers early in at least a subset of these patients. MRI, by some measures, does appear to downstage patients. This is data from Ellen Warner's study, which has been running up in Toronto for quite some time, where she showed that patients entering MRI screening programs, actually combined MRI mammographic screening programs, didn't appear to have overdiagnosis because the incidence was the same, and yet the stage at diagnosis, or at least the probability of being diagnosed with advanced stage disease, was significantly lower. Now, it's unlikely that we're ever going to get to a mortality endpoint in a randomized controlled trial in BRCA mutation carriers, unfortunately. So we're always going to have to rely on these types of surrogate endpoints. And unfortunately, they may not be ideal because there's increasing suspicion that MRI is not perfect in some of these patients. These are some data that were collated by one of the Dutch groups looking at the 3 big MRI screening studies in Holland, the UK, and the US. Even those that were engaged in MRI screening programs still had a relatively significant incidence of interval cancers, and still nearly 50% of the patients, despite doing MRI screening, had T1C or T2 tumors at diagnosis. Although most of them were node negative, unfortunately in BRCA1 associated disease, 80 to 85% of those are going to be triple negative, and picking up T1C or T2 triple negative cancers is not a win necessarily. Those people are still going to have to go through probably chemotherapy and have a significant mortality risk despite screening. BRCA2, on the other hand, screening does appear to be more effective. There's pretty good evidence that advanced stage disease with people undergoing careful and routine screening in the BRCA2 context tend to be picked up pretty early. And so maybe there's a difference. Maybe for BRCA1, MRI surveillance is not such a great idea, or at least is not as likely to be effective as for BRCA2. And you can already see that what's starting to happen is, as we get more information, we're able to start segregating our screening recommendations and our discussions based upon not just the gene itself, but a lot of additional clinical factors that have become available over time. Now, there's a lot of work being done trying to improve enhanced surveillance strategies. There was a presentation at ASCO a couple of years ago looking at biennial MRI, where in a small group of patients, there was a fairly significant downstaging compared to the conventional annual MRI alternating with mammography. Not a randomized study, but a very interesting observational study. Unfortunately, biennial MRI is pretty expensive, significant risk of false positives, and not something that the payers are particularly interested in supporting. So one thing that we and others have been looking into is contrast-enhanced mammography, which is about 1/10 of the cost in the US and does seem to be incrementally at least better than conventional mammography and might be an interesting substitute. So there are other groups that are looking at other technologies to try to improve the surveillance aspect of things. But we're still left counseling people about this very, very difficult choice, which is, should I embark upon screening? Should I embark upon surgery? And we don't, and we never will have randomized control data to guide them. And so it's always a gestalt. And there's an important attempt to try to bring a little bit more quantitative information here. This is a model that was generated by Alison Curian out in Stanford. And what she did was taking performance characteristics of MRI and some predictions about what one could expect in terms of outcomes from cancers diagnosed at different stages. She has been able to generate predicted impacts based upon different interventions at different ages. And you can try this tool out if you're interested in seeing what it gives you. At the end of the day, what it does is it produces these tables which you have predicted outcomes based upon different interventions at the different ages. And so just as an example, in this table, for a BRCA1 carrier who's between 25 and 29, if you do nothing, in the far left column you can see what you would predict, and unfortunately what you would predict is about 40 of those women are going to be dead of breast or ovarian cancer by the age of 70, whereas if you do enhanced surveillance and then an oophorectomy at age 35, you drop at least your breast cancer death rate down to 6 women by the age of 70, and then if you do a mastectomy instead of surveillance at age 35, you drop it down to 2. So in other words, the incremental benefit of bilateral mastectomy is 4 breast cancer-related deaths by the age of 70, which is perhaps a lot lower than one might expect. For BRCA2, the benefits are even less because screening is thought to perhaps be a little bit better, the cancers are more easily treated, and in this setting, a prophylactic mastectomy strategy at the age of 35 really only reduces the breast cancer death rate by 2 patients. So again, it might be worth it, but it's not a particularly huge increment. Now, the problem is models are models, and models are based on assumptions, and assumptions may or may not be correct. But under these assumptions that Alison's been producing, the survival impact of a routine prophylactic mastectomy strategy might be considerably less than expected. And the survival impact falls with age and with competing risks. So one thing that we see very commonly, and I don't know what your experience is that a woman will undergo enhanced surveillance until she develops a cancer, and then at the point she develops a cancer, she decides to have a bilateral mastectomy. I can completely understand the emotional rationale behind that, but from a completely health outcome standpoint, it makes no sense. Because once she has developed the cancer, now she's introduced a huge competing risk, which is going to undermine any potential benefit from the prophylactic surgery. But anyway, the models assume that oophorectomy is going to have a significant effect on BRCA1 associated risk, which may or may not turn out to be true, and it assumes an equivalent performance of MRI in BRCA1 and BRCA2. But we have to also recognize that for patients, these hardcore survival endpoints are not necessarily as important as just the simple reduction in anxiety. The other thing that we have to remember is that breast cancer is not the primary reason for doing BRCA testing. The primary reason is this, high-grade serous papillary ovarian cancer, because this we can't screen for, this has a very high mortality rate, and this is something that you can prevent with a relatively high degree of efficacy by doing preventive surgery. So at the end of the day, although this is a breast cancer conference, we're talking about a lot of breast surgery, prophylactic ovarian surgery is really probably the most important reason to do the test. So what have we learned from BRCA1 and BRCA2 that we're going to bring forward into the next generation of testing? We've learned that testing thresholds are largely arbitrary, and they're determined by some societal consensus about the acceptable cost per positive test. And this is susceptible to technological advance. As the cost of testing goes down, either because of patent expiration or because of next generation sequencing, it gets easier to do testing. The cancer risks are variable, but whether or not more precise estimates are going to be helpful is not entirely clear because patients don't necessarily make decisions based on quantitative risk estimates. And the clinical utility, and this is important, we always have to keep in mind, why is the test useful? In unaffected women comes from 2 things: guiding people about the need for salpingo oophorectomy and allowing people who are truly negative, who don't have a mutation, they come from a family where there is a mutation, to relax. And keep those things in mind as we're moving forward and talking about testing for new genes. Thank you very much, and I'd be happy to answer any questions by email or, I guess, later on in the conference. Appreciate your time.